Okay, so I did my report on chronic kidney disease. The etiology of chronic kidney disease is pretty difficult to determine because there are so many possible causes. Those include amyloidosis, FIP, glomerulonephritis, neoplasia, nephrolithasis, polycystic kidney disease, pyelonephritis, tubulointerstitial disease, acute kidney injury, loss of nephrons, etc. The most common is thought to be tubulointerstitial disease. Clinical signs, the most common is PUPD. That's due to the body trying to compensate for the poor filtration of the kidneys. You might also see weight loss, loss of appetite, nausea and weakness, or lethargy. That can be due to the buildup of toxins in the blood, causing the patient to feel nauseous and stop eating. Vomiting and diarrhea is also seen in these patients that promotes weight loss and dehydration. High blood pressure can be seen in patients with CKD as a result of either dehydration or lack of erythropoietin being produced by the kidneys. Also, pale mucous membranes goes along with the lack of EPO and dehydration. For diagnosis, blood work, urinalysis, ultrasound and radiographs, and biopsy can all be used. On a CBC, you might see an anemia that can be due to the low levels of EPO. On chemistry, we typically look at BUN and creatinine. If they're both high, then the patient does have azotemia, and that's a really good indicator for CKD. A normal BUN concentration is 16 to 36 milligrams per deciliter, and creatinine is 0.8 to 2.4 milligrams per deciliter, according to IDEX. Phosphorus is also a value that we look at. So normal phosphorus is 3.1 to 7.5 milligrams per deciliter, according to IDEX. Phosphorus is controlled by parathyroid hormone and vitamin D. And with kidney failure, parathyroid hormone levels rise and vitamin D fall. And parathyroid hormone will start to pull phosphorus out of the bones, which makes them brittle and prone to fractures. On urinalysis, we look at specific gravity to see how well the kidneys are doing at concentrating the urine. You might also see proteinuria and bacteria, and a culture and sensitivity might be needed in order to properly treat an infection. Ultrasound and radiographs are used to evaluate the size of the kidneys. So, a large kidney can indicate lymphoma or amyloidosis. Small kidneys are very indicative of CKD and normal sized kidneys, but other signs of chronic kidney disease, along with the normal kidney size, could mean that you either caught it early or it could be an acute disease process. A biopsy is typically done in young patients with large kidneys, and it's very, very, very important that you test clotting factors prior to doing a biopsy on the kidneys, since the organs are very highly vascularized, and if they can't clot properly, then the patient will lose a lot of blood, and that's just not good. So before doing a biopsy, test clotting factors. Another test that can be done is the IDEX SDMA. So IDEX SDMA stands for systemic symmetric dimethylargine. It can detect as little as 25% loss in kidney function, and it is a really early indicator, earlier than other parameters will show. And I have an example of that in just a minute. It has been added by the International Renal Interest Society to their staging guidelines for chronic kidney disease. So for treatment, obviously treat underlying issues. You might need to do a blood transfusion or give a dose of human EPO to treat an anemia. Enalapril and benazepril are both ACE inhibitor drugs, which can help stop protein loss. Amlodipine can be used to control blood pressure. And then if the patient is vomiting or nauseous, you can use anti-nausea and antiemetics. The main treatment for chronic kidney disease is diet. So diets low in protein, phosphorus, and sodium, and then high in water soluble vitamins, fiber, and antioxidants. It is important when choosing a diet for a CKD patient that you choose one with high quality proteins. Low quality proteins cause the kidneys to work harder, so eggs and meat will help lessen the load on kidneys. Okay, so I pulled this case study from the IDEXX website. It's about their SDMA test. A 13-year-old male domestic shorthair presented for just annual exam and vaccines. He's an indoor-outdoor cat, had no issues or concerns. He was BAR, vitals were within normal limits, and he had a good body condition score with no significant findings on physical exam. The doctor did note that he had moderate periodontal disease, so a dental was recommended, and samples were taken for his pre-anesthetic profile, including a CBC Chem, SDMA since he was a 13-year-old cat, and total T4 and urinalysis. So his diagnostics came back. He had an increased SDMA of 23 micrograms per deciliter, and the reference range for that is 0 to 14. His specific gravity was low. It was 1015 when normal is around 1030, but he had no other significant findings on his diagnostics. So the owners were instructed to provide more access to water, and they also switched to a senior diet, and a recheck appointment was scheduled for 2 weeks later. At his recheck, his SDMA was still increased. It was at 19 micrograms per deciliter this time. His specific gravity was exactly the same, and then an ultrasound on his abdomen was performed. It did show small kidneys, which is consistent with chronic kidney disease, and his blood pressure was taken. It was 175 milligrams of mercury, and it increased when it was rechecked a few days later. So the patient was diagnosed with chronic kidney disease stage 2. He was placed on blood pressure medication and switched to a kidney therapeutic diet. I thought that this case study was pretty interesting because without the SDMA, they might not have caught anything since his CBC and chem came back normal. Some important reminders for dealing with CKD cases are that they are very, very common in veterinary practices, and it's important to remember that every patient comes in with different signs. They need individual treatment, so it's easy to get caught up in just treating the same thing the same way every single time. But it's important to go into each appointment and case with a clear mind, pay attention to that specific patient and their needs. Like Dr. Santonzi says, the most important patient is the one in front of you. And these are my citations.